there actually remarkably wasn't that much on the web on living well with heart failure. This is from the Australian Heart Foundation. They actually have a brochure, but when you look at it, it's really telling you a little bit about heart failure and then kind of how to control heart failure, especially with attention to fluid intake and sodium intake and being on the appropriate medications. I think it's always nice to kind of put things into context. So I have a couple cases I want to show you, and then we can chat a little bit about those. So the first one is an 84-year-old gentleman, ischemic cardiomyopathy, has coronary artery disease, so had a previous CABG. You can tell by all the sternotomy wires here on the X-ray. His ejection fraction significantly impaired. He's 20% as per an echocardiogram that was carried out. So he got a CRT ICD, and you can tell it's an earlier generation one because this device is pretty big. Our current generation devices are smaller than this. And you can see he's got a large number of wires in the heart. These thick wires are the ICD leads. He had a lead that was on recall. So what they do is they just leave the lead in and put another one in. You can see he's got a couple pacing wires there as well. Now, despite the CRT-ICD platform, he had several admissions for heart failure over the years, and there were challenges in terms of optimizing his medical therapy because of hypotension. So he actually went and was initiated on in-hospital IV milrinone. So milrinone is an inotrope. When you receive it in hospital, it's almost like being on dialysis. It's 3 times a week, 6 hours a session. We don't do very much now, but about 10, 15 years ago, we had a few patients on this. The reason we don't give it orally is because of this now 30-year-old paper that shows that there's a mortality risk associated with oral milrinone, probably because of dysrhythmia. And the thinking is, when we administer it in hospital, at least we would monitor for things like that. So he started on the milrinone. He does well for 4 years, and then he has a fall. So he has a subdural because of that. It's December 2008. His care team thought his prognosis wasn't great, so palliative care was consulted. And with the palliative review, we saw that several new symptoms were noted, including kind of early satiety, anorexia, fatigue, and just weakness. Some significant dyspnea was also noted. So I'll just get everyone else maybe to put their microphones on mute, and then we won't have any crosstalk. So some symptom recommendations were made, including starting morphine for dyspnea. I'm challenged many times when I have these conversations with our patients because they're afraid of narcotics. I think because it's a drug of abuse, certainly out in the community. And he declined the narcotic, and he kind of declined a lot of the other recommendations made by the palliative team. He also has an active ICD, so people started talking about, is that something you want to continue, the ICD shock therapies? And he said he felt strongly about maintaining all that. So he's discharged. He continues with milrinone for a couple more years, but he's changing. His pressures are getting softer, and he's not really tolerating the full dose of milrinone. In fact, it had to be discontinued a couple of years later because of more hypotension and progressive weakness. Like he just was finding it difficult to get to the hospital for the milrinone infusions. At that point, kind of palliative became involved again as ICD therapies were again reviewed, and again he wanted all of his therapies maintained. Patient then died later that year, just in December, and that's about 10 years after first being hospitalized for heart failure. So I want you to contrast that with this second patient. So he's a 27-year-old male, muscular dystrophy, was referred to a cardiologist at 24 years of age because of frequent palpitations. Maybe what I'll get you to do is, let's see, let me move to the next slide. I'll see what people's thoughts are in terms of what this rhythm strip shows us. So maybe just in the chat, and you can do it privately to me if you don't want to share it with everyone. Just put in your guesses in terms of what this rhythm strip shows. So is it normal sinus rhythm? Is it frequent PACs? Is it atrial fibrillation, or is it PVCs? So far, we have one brave soul who's put in a response. I'll give you just a few seconds for other people to kind of weigh in. I should have put an E in there, no idea, because I'm getting a few people putting that down. What this is they're PVCs. You can see the P wave, QRS, and then something wider coming in fast. P, QRS, and couple, and then a wide beat, another narrow wide beat, and then a couplet of wide beats. So this is just frequent PVCs, and that's the reason he got the ICD. Well, I'm jumping ahead of myself. He had an echo that shows the ejection fractions down at 45%, and he ended up getting an ICD because of the frequent PVCs. It was thought he'd be at risk for ventricular tachycardia. But, you know, he kind of struggled. He had lots of heart failure presentations even after the ICD went in. And he, a couple of years later, presents to the emergency department with dyspnea. Initial investigations are pretty unremarkable, so he was sent home. Then he comes back 3 days later with more severe dyspnea, now has a lot of metabolic abnormalities. His creatinine's up, his sodium's down. So cardiology saw him, admitted him. His pressures are really soft, so he had to be started on IV inotropes as well. So on day 1 of hospitalization, an echo was carried out and showed that his EF has decreased now to 15%, so significantly impaired from where it was before. His second day of hospitalization, you know, just general worsening despite being on inotropes. His pressures are still soft. His kidney function's getting worse. So on the third day, he was reviewed by the cardiac transplant team. And unfortunately, he wasn't a cardiac transplant candidate because of his muscular dystrophy history. Also, he wasn't a candidate for an LVAD, which we put in many times in a number of patients. On the fourth day of hospitalization, it was decided that we just weren't winning and we need to kind of take a step back from aggressive therapies. His ICD therapies were reviewed and discontinued. Palliative care was consulted, and then he died the next day. Okay. And then one more case. So 58-year-old male, he's got coronary artery disease. He had a non-STEMI complicated by a VFib arrest in September 2017. Fortunately, he was in the hospital when he arrested, so he was successfully resuscitated. He had an angiogram carried out at that time, and he had widespread coronary artery disease, but he had no real interventions either by stenting or bypass surgery. His vessels were so diffusely involved with the coronary artery disease. He also has ischemic cardiomyopathy. His EF's about 18%. Because of that, he was reviewed by a cardiac electrophysiologist and offered an ICD, which was declined by the patient. Unfortunately, he's not a transplant or a VAD candidate because of his comorbidities, including type 1 diabetes with poor renal function. You can see down here the GFR is impaired at 30 mils a minute. He's also got AFib, and he's on amiodarone for that. I've been following him for about 3 years in my palliative cardiology clinic. The thing that we've done is, our major intervention has started him on a little bit of a fentanyl patch for relief of dyspnea, which he's found to be helpful. He's R2 goals of care. This is kind of what our goals of care landscape looks like. So R2 would mean he'd still accept, going to ICU, resuscitation, and intubation. The only thing he wouldn't want is chest compressions. Having said that, he kind of doesn't want an ICD. So we have a little bit of a disconnect there. So let's look at these studies. So our 84-year-old lived for 10 years after getting his defibrillator, passed away 3 years after the initial palliative care consult, and he died at home. Our 27-year-old lived for 2 years after getting his defibrillator, passed away 1 day after the palliative care consult. He continues to be doing well kind of 3.5 years after his cardiac arrest. So what do these cases show us? Well, before I show you kind of my thoughts, what do you guys think in terms of what these cases show us? Anybody? So lifestyle, genetics, everyone's different and the heart is complicated. Yeah, I like that. So there's a wide spectrum of heart failure patients. Clinical courses can be vastly different. Prognostication is really challenging. So that first patient, I don't think anyone would have predicted he'd live for 10 years. The second patient, he had a much shorter time course, I don't know if people would have predicted it would have been that short. And then our third patient, is still doing well 3.5 years after his cardiac arrest. He's at significant risk of having another arrest and hasn't done so yet. So it's really hard to prognosticate. And in general, palliative care typically becomes involved quite late. Certainly that was the case for our second young patient with muscular dystrophy. For our first case, palliative care got involved earlier, but weren't able to make any real meaningful avenues. The last case is an example where we have some nice collaboration between palliative care and heart failure. What I wanted to do today to kind of build up the story of, how we can help patients do well with heart failure is review a little bit of the history of heart failure management, talk about how hard it is to kind of predict the future, and talk about barriers to kind of getting palliative care involved in these patients. So let's look at the history. But before that, to put things into perspective, let's look at kind of how people died back in 1900. So the question on the table for you guys is, what was the average age of death in 1900? What do you think the top 3 causes of death were? How long were you unwell before you died? And where did you die? So feel free to answer any of those questions in the chat box for a little bit before I give you the answers. How long do you think people live for on average?
50, 60.
Okay. Yeah. So I'm seeing lots of kind of a range of answers: 40s, 50s, 60s to 70s, 38. So the average age is 40. Okay. Top 3 causes: infectious disease. You have to recall in 1900, we didn't have any antibiotics. Accident was also a big cause of death. We didn't have great trauma care, and even childbirth was fraught with mortality. Generally, patients were unwell only a brief period of time before they died. And where did they die? At home, usually surrounded by family members, maybe spiritual care advisors. So same questions on the table now, but for a contemporary practice. So I know we've got a lot of patients with us here. I'm wondering what your thoughts are about kind of the average age of death, the top 3 causes of death, how long you're unwell before you die, and where do you think people are dying? You're in 70, okay. You're in 86, 75, in terms of causes: cancer, heart disease, COVID, yeah. So let's actually take a look. So the average age of death is 80, okay. Top 3 causes are cancer, organ failure, and so in that I would include heart failure, lung disease, kidney disease. Frailty and dementia is also a significant cause of death in our current kind of medical climate. How long are people unwell before they die? This is really variable from weeks to months, sometimes years, and it's really hard to predict. And then were people dying? I think for the most part, a lot of patients, especially non-cancer patients, are dying in hospital. And yet when we talk to patients and ask them, where would they like to be for the end of life, it's not the hospital. So we have a disconnect there. I throw up this slide just to show kind of how life expectancy is predicted to continue to increase. And when we hit 2080, I don't know if I'll be around then, on average, people will be living to 100 predicted. So at this point, I want to take a step back and ask, how do we manage heart failure? And again, it's always nice to take a historical perspective. So in the 1950s, I'll let people guess a little bit, and I know some of our patients might not be well versed in this, but what do you think we did? How did we treat our heart failure patients? And I've broken it into non-pharmacologic, pharmacologic, and devices, and I'll help you out and say that we didn't have any quote unquote devices in the 1950s. What do you think we did?
Some drugs.
What's that, sorry?
Only the drugs.
Only the drugs, okay. Yeah, let's see. So we had a few drugs. We had digitalis, which is an old drug, digoxin. We had morphine, which we'd use for breathlessness. We had diuretics, so this is the class of medication that Lasix belongs to, but we didn't have Lasix yet. We had kind of mercury-based diuretics, so the precursor to Lasix, and they had to be injected with intramuscular shots. In terms of non-pharmacologic, here's the things we recommended. We did kind of recommend what we're recommending now in terms of restricting sodium, but we said you should stay in bed and you should rest. We also did phlebotomy, meaning bloodletting if patients had too much volume on board. So if we go to the 1960s, on the non-pharmacologic side of things, we're still advocating for the bed rest, still advocating for the salt restriction. The advantages we've made is now we've got a few better drugs. We've got the diuretics, the water pills, and we've got several options of them. We've also got inotropes, so medications that help us to support the heart when it gets weak. Also, we were starting to take a step back and say, why do patients get heart failure and what can we do about it? Okay, so looking for infection and other causes. And we're starting to see some devices, so pacemakers, balloon pumps, external defibrillators. And then in the 1990s, we got prolonged bed rest being replaced by ambulation. We want to encourage people to be active. My nice example of there is in cardiology, we look at the literature in detail and we have lots of clinical trials because there's lots of patients with heart disease. And we found that patients with dogs live longer. Why do you think that is?
It's an introduction with somebody.
Yeah, I'm seeing a couple themes and whoever spoke out, I think you're addressing both of those themes. So one of them is activity, exercise, especially when it gets to be winter in Calgary. I don't know about the rest of you, but I certainly don't like getting out unless I have to. We have a 4-year-old lab that has to be walked every day. So I was out yesterday in the cold, grudgingly, but I was out there doing that. And so other people would have to do that. I can't minimize also though the mental health and companionship that animals offer. And because of both of those things, we're seeing kind of a benefit. And I know that some cardiology programs in the United States, some wellness programs have gone so far as recommending some of their patients consider getting a dog. Clearly lots of considerations there, including all the responsibilities that come with that. We also have more devices. We have defibrillators, we have fancy pacemakers, and we have kind of artificial hearts, ventricular assist devices coming on board. Now, with all those advances, patients are doing better. They're living longer, and this is data that goes up until 2010. It looks at, as we move across the decades, people are living longer on average. Having said that, the mortality associated with heart failure can still be significant, and it could be higher than many cancers like ovarian cancer, colon cancer, and breast cancer. Only lung cancer really has a higher mortality than heart failure. Let me throw out this question to everybody. How often do you think palliative care gets involved with heart failure patients during a hospitalization? I apologize if I'm making people work. I'm sure you didn't come to this thinking that you're going to have to be answering a whole bunch of questions.
It's less than 10%.
Less than 10%. Yeah, that's the answer. I want to talk about now something that we as physicians are asked to do not uncommonly, and that's predict the future. And I will say that we're not good at it. but how not good are we? So again, a question for you: how well do we prognosticate? Is it very poorly, poorly, average, relatively well, or very well? I've already told you we don't do it very well, but what do you think?
I would say A, very poorly.
Yeah, we got a few A's, we got a few D's, relatively well, some C's. The answer is very poorly. And here's some data I'll just quickly show you. This is data from the United States asking doctors to predict how long people are going to live for. And these are people that have been sent to hospice, so have kind of an end-of-life illness. And it's kind of a big mess, but it shows that on average, doctors are over-predicting how long patients live for. And I think one of the reasons for that is if we compare our disease trajectories, you've got in cancer, you've kind of got a decline and then what I call like an inflection point and a quicker decline. But in heart failure, you've got a general decline and then you've got this roller coaster ride superimposed, and that you might have a heart failure exacerbation where your heart failure gets a little bit worse. And it's difficult to say how much you might come back from any individual kind of heart failure exacerbation. I'll just skip this part. Now, clearly I'm biased. I'm both a cardiologist and a palliative care doc, and I think there is significant benefit from having a palliative care doc involved in the care of many of our patients with advanced heart failure, especially if there's a significant symptom burden there. But we don't see it happen that often, and you saw the stats of how infrequently that happens in hospital, and there's several reasons for that. So number one, predicting the future. That's hard, and I think that that's a significant barrier. Then also, I think there's misconception on the part of both patients and physicians. In terms of patients, it's about what palliative care is. I don't know if people really have a good sense of that. A lot of people equate palliative care with hospice, and they're two very different things. Also, perhaps misconception about prognosis. If I was to sit down with someone in my clinic and say, Mr. Brown, do you have a sense of kind of where we're at and what the future will hold? He'll say yes, but if I was to challenge him about timelines, only about half the time would he get it right. And this is a slide that just kind of shows that in terms of comparing what a model would predict for life expectancy, which would be on average about 10 years, and what patients would predict. You've got some patients predicting 40 up to 50 years. So a bit of a disconnect there. There's also a misconception about how effective some of our treatments are, and I'm just in the interest of time, I'm going to kind of bypass that. There's perhaps an unwillingness of cardiology to kind of seek kind of additional help, with several concerns, maybe some of them that the advanced heart failure therapies will conflict with the concepts of palliative care, which they don't. And there's always the ongoing hope for new therapies, and Tresto is one of the new therapies that many of you may be on that indeed has, been shown to have kind of a benefit both symptom-wise and longevity-wise. There's also the perception that palliative care could potentially take away hope. And, that's certainly not the perspective that we're coming from. And I like, again, going back to the literature, as cardiologists, we have a huge literature base. And this is one paper that I kind of share with some of my colleagues and some of my patients, that we're not the Grim Reaper service. And really, I think what this is getting at is, again, a misconception about what palliative care is. Just in the interest of time, I'm going to skip that. I think another barrier is end-of-life conversations. Sometimes on the patient part of things, these aren't initiated because there isn't an awareness of sometimes of prognosis. And on the physician side of things, we look for kind of moments to do it, and we don't necessarily have them. Other kind of factors are lack of time. It takes time to take a step back and talk about these things, afraid of destroying a sense of hope. The literature shows that in general, we don't do that though when we have these conversations. Uncomfortable building it up, for sure, bringing it up, and for sure that can happen. And perceive that patients aren't ready to talk about it, perhaps, but I think physicians are equally unready to talk about it. This is what kind of a goals of care conversation might look like in the hospital. I don't know if you've seen this or not. And again, we have three general categories: resuscitative, medical, and comfort. With those kind of categories, as we move successfully down the list, we kind of start to focus more on symptoms and less on kind of interventions. I'm just going to spend a minute kind of talking about resuscitation because it's an interest of mine, and it's always nice to know where we came from. So, you know, you've probably seen CPR, if not anywhere, at least on television. And the reason I necessarily have the time to open up the heart. So researchers were looking at models for defibrillation, so putting the pads on externally. And what they did is they used a dog model, because we used animal models for work like this. And you know, they'd have these dogs in special experimental labs, and they'd have the defibrillator pads on. And to keep it as realistic as possible, they wouldn't shave the dog hair. To keep it as realistic as possible. And sometimes, you know, the hearts would go into ventricular fibrillation and they'd go to shock the heart, but the pads would have fallen off. So they went to put the pads back on, but they found, there's a pressure signal. And they thought, okay, what if we do this repeatedly? And that's how CPR came to be. And you know, CPR has its role for sure. When we're in the hospital, we get called on various codes not infrequently. I think the point to take home is that, you know, the success rate, even in the hospital, is far from 100%. The overall success rate of a cardiac resuscitation is about 15 or 20%. If it's because of a cardiac reason, it's usually because of a shockable rhythm. And for those patients, it's about 35 to 40%, so a bit higher, but still not what you might think it is. And in terms of, you know, what you might think it is, you know, I ask the question, where do we get our information from? And usually it's social media or television. So I like this paper in the New England Journal of Medicine, one of our main sources of reference in the medical literature. And in 1996, they looked at TV shows that were going on at that time, 3 of them, Chicago Hope, ER, and Rescue 911. And I have to be honest, I don't think I've ever seen Rescue 911. It's a paramedic-based program based with people like William Shatner. And they asked, what is the success rate of CPR on those shows? And they found that, you know, on average for Chicago Hope and ER, it was about 2/3 success rate. And Rescue 911 was 100%. So I give this paper to my residents, so my junior trainees, not infrequently, just so that they can kind of see what the literature shows about these things. I think if there's a take-home message from the paper, maybe it's that hopefully if you're an actor, you were on Rescue 911 because you would have lived to act another episode on that series. So going back to the initial question I was asked, you know, what does living well with heart failure mean? To me, I think, for, you know, for those select patients, it probably means getting palliative care involved, or if not palliative care, at least someone to kind of attend to the symptoms that you're having. Because I think in addition to kind of having heart failure, you know, the direct cardiac issues, there's lots of other things going on, including breathlessness. And really, you know, are you achieving kind of the goals that you want? I not infrequently use narcotics, so opioids, for breathlessness. Again, they're really scary for a lot of people. The way that I look at it is the right drug at the right time, at the right dose for the right patient. You know, we're seeing a lot of, you know, bad effects from narcotics out in the community, but that's from them being used as kind of drugs of abuse. So I think with that, I'm going to stop and give people an opportunity to kind of ask some questions.
Thank you, Mike, for this awesome presentation. So if you have any questions at this time, I'm going to stop the recording and then we can begin our question and answer period. So feel free to type it in the chat or unmute yourself.